to us on when there are good homes, there will be good health, Maori housing and health in Auckland, 1935 to 1949. This is based on Ella's PhD thesis, which she completed last year at the University of Auckland, exploring aspects of Maori health in Auckland and Tamaki Makaurau from 1918 to 1949. I met Ella at the history conference when I was talking about one aspect of the Maori Councils Act, which had led to the first requirement in New Zealand for, sorry, I'm just going to turn that off, requirement for subfloor ventilation, which had not been a requirement in any of the Pākehā building codes up to that date. So it was interesting to find the way the world worked. In fact, it come from some very interesting areas. But I'm going to pass over to Ella and let her talk about her work and look forward to an interesting discussion afterwards.
Kia ora koutou. Ko Ella Arbury toku ingoa no Tamaki Makaurau a home, ke paiti mokai e o noho ana. No reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. Sorry, just trying to there we go. Before I begin my talk today, I want to make a quick disclaimer that although I currently work at the Waitangi Tribunal Unit, the research for this presentation was carried out independently when I was a PhD student and is not connected in any way to my work at the Waitangi Tribunal Unit. Concerns about child health, tuberculosis, influenza and other infectious diseases shaped debates about Māori health and housing during the 1930s and 1940s. I will examine the first Labour government's responses to these health concerns and their increasing efforts to help with the housing needs of Māori migrating to Tamaki Makaurau, Auckland. Māori housing in Auckland provides a window into the relationship between government health and housing policies. Government housing policies aim to improve Māori health by reducing overcrowding, considering sunlight and ventilation, improving sanitation, and the use of design features such as sleeping porches.
Introduce you to that.
Okay. This was in line with other contemporary efforts to improve health, especially children's health through better housing. However, the Second World War and severe housing shortages hampered these efforts to promote Māori health through improved living conditions. Government housing initiatives for Māori during the second half of the 1930s focused on rural housing. The 1935 Native Housing Act, initiated by the United Reform Coalition government, and continued by the first Labour government, established the Native Housing Program, which enabled the Department of Native Affairs Board to lend money to improve rural Māori housing. Under the scheme, Native Affairs provided mortgages to Māori families to have houses built on their own land or to improve existing homes. Ideas about health shaped these houses' design, but not all of these ideas could be implemented due to the need for housing repayments to be affordable. According to a 1937 memorandum to the Native Affairs Board and members, come on in. Adequate floor space to prevent overcrowding was the most important factor. However, the memorandum also stressed that all houses should have a bath for piped hot water supply, but the high cost of hot water tanks and associated plumbing meant that many Native Affairs houses built during the late 1930s did not include plumbed in hot water. This was in contrast to contemporary style houses, which were only available to Pākehā families until the mid-1940s, which all had piped hot water. Despite the fact that the Native Affairs program's dwellings were built to a lower standard than state houses from the mid-1930s to the late 1940s, this scheme was still viewed positively by some Māori. An example of this was when Uruwera Tirika Tene, the Ratana Labour MP for the Southern Māori electorate, stated in 1937 that the program gave, quote, new hope for Māori. According to Tirika Tene, many Māori were living in unhealthy housing due to earlier government's actions, which had, quote, deprived them of almost all they owned, end quote, by taking most of their land. The numerous applications for Native Affairs houses also demonstrated the scheme's popularity. By 1938, around 12 plans have been prepared for Native Affairs houses. You can see one of the plans here on the slide. All plans included a living room, which would also be used for cooking as shown on the slide. I don't know if you can make out, but here we've got the sink here, sink bench, and we've got the cooking range. and a bathroom. These houses were designed to reduce building costs to keep them affordable. Some of the houses were planned so families could build on extra rooms once they could afford it. This house plan includes dotted lines to show these potential future rooms. Got these dotted lines going around here. While Maori housing policy during the late 1930s focused on lending money to build rural houses, many Maori were migrating to New Zealand cities, especially Tamaki, Makaurau, Auckland, and Te Whanganui Atara, Wellington. A number of factors causes migration. Come on in. Many tribal economies, such as those in Northland, were exhausted following the 19th century loss of land and the early 1930s economic depression. More jobs and better educational and career opportunities attracted Māori to urban areas. In 1938, the Auckland City Council carried out a housing survey which found many Māori families who had recently migrated to Auckland living in, quote, unhealthy and unsatisfactory conditions, end quote. Alan Moody, the chair of the Auckland Hospital Board, visited some of these dwellings in central Auckland. He was concerned that these unhealthy conditions would lead to sickness, which would incur hospital treatment costs for his board. In May 1939, the Young Māori Conference took place at the University of Auckland. This conference attempted to find solutions for issues affecting Māori, including health and housing, especially in Auckland, whereas a conference delegate stated, Māori problems were more acute than anywhere else. Many of these delegates asserted in various ways, quote, when there are good homes, there will be good health. Conference delegates expressed particular concern about the health disparities between Māori and Pākehā and the need to improve housing to promote Māori health. Dr. Harold Turbot, the Medical Officer of Health for the South Auckland Health District, presented at the conference and provided Māori health statistics to its attendees. According to his statistics, Māori infant mortality, tuberculosis and infant mortality rates were much higher for Māori than Pākehā. Turbot linked these higher rates to housing additions. He also provided statistics from Māori housing surveys, which showed that 57% of Māori homes surveyed were overcrowded, 36% were unfit for habitation, and 45% had an inadequate water supply. Māori urban migration continued to occur on an unprecedented scale during the Second World War. In 1935, approximately 1,766 Māori lived in Auckland. This had increased to around 10,000 by 1943. During the war, more than 2,000 Māori worked in Auckland's essential industries, with many young Māori women working in boot and shirt factories. Now, I'm not sure if the women in this photo are Māori or not, but as you can see, these women are making military uniforms, so that was a popular thing. My own grandmother made military uniforms in Auckland during the Second World War. She also illegally made gowns to sell on the black market to American soldiers, but we'll just focus on the military uniforms here. Many of the privately owned houses available to Māori families lacked sanitary facilities or were too small for their needs and were often located in slum areas. Historians Nancy M. Taylor, Melissa Matutina Williams, and Sibel Locke have written about racial discrimination for Māori migrating to Auckland. This discrimination for privately rented dwellings appears to have led to many families inhabiting overcrowded or substandard housing. Maori hostels were established in Auckland during the Second World War to provide healthier living conditions for young Maori urban migrants. Maori hostels were also set up in other New Zealand cities in the 1940s, including Wellington. The United Māori Women's Welfare Society was instrumental in founding these hostels in Auckland. A group of Maori mothers created this interdenominational and intertribal society. They established hostels in conjunction with charitable organisations and the government to help, quote, Maori girls and lads living in crowded, unhealthy places. In 1944, the United Māori Mission opened a hostel for young Maori women at 29 Hepburn Street in Ponsonby. So we can see the picture of this lovely old house on the slide. I was practicing giving this talk to my son the other night, and he said, Mum, you've got a slide, but it's actually just a fire escape. So just in case you were wondering, is it a slide? But no, it was just a beautiful old house that was repurposed. During the 1940s, Auckland newspapers published articles about unhealthy Maori living conditions in the city. Many of these articles linked overcrowding with tuberculosis and saw overcrowding as a barrier to reducing the higher Maori rate of this disease. A 1943 Auckland Star article included a description of a recent tour of some unhealthy housing conditions in Auckland. Arthur Richards, a Labour MP for Auckland's Roskill electorate, joined this tour. The article claimed that Richards' visit provided a, quote, disturbing revelation of the overcrowded conditions on account of the housing shortage, end quote. One family with 4 adults and 6 children were occupying a basement room with a dirt floor and no source of natural light. An unnamed person living in another basement room told Richards they were unable to rent a house because, quote, people refused to let because they were Māori, end quote. Unhealthy housing conditions for Māori were not limited to Auckland. Many struggled to find healthy housing in other towns and cities. New Zealand's 2 largest cities, Auckland and Wellington, had the highest rates of Māori urban migration. These cities also had the most severe housing shortages during the Second World War. Unhealthy housing also persisted in rural areas, despite urban migration and the native housing program's construction of rural dwellings. These unhealthy living conditions led to calls for more government funding for Maori housing around New Zealand to promote health. An example of this was in 1945 when Tiaki Omana, the Ratana Labour MP for the Eastern Māori electorate, stated, quote, wretched Māori housing was the real cause of much sickness. And if the scourge of tuberculosis were to be cured, a start must be made from the angle of better accommodation, end quote. The Health Department also called for better housing as part of its attempts to deal with tuberculosis. Claude Taylor, the director of the Tuberculosis Division of the Health Department, reported in 1945 that tuberculosis patients who had been treated in hospitals or sanatoria needed to be provided with adequate housing following their discharge. Come on in. According to Taylor, the improvement of housing for the Māori is recognised as an important factor in producing a decrease in the incidence of the disease. As a temporary measure, an increasing number of hutments are being supplied. As you can see, this is a hutment. Hutments were small prefabricated shelters for tuberculosis patients and were intended as a short-term measure until there were enough affordable homes with sufficient bedrooms or sleeping porches for all, quote, tuberculous families, end quote. I think they look a little bit like tiny houses. I don't know if any of you are into tiny houses, but maybe a bit of a precursor. By 1943, over 100 hutments were in use for Māori tuberculosis patients across the country. In 1944, the Auckland Māori Tribal Executive Committee lobbied the Prime Minister Peter Fraser to improve Māori housing conditions in Auckland. This committee, established in 1942, was an intertribal organisation to help Māori in Auckland. Kelly Harris, the committee's secretary, wrote to Fraser that the committee wanted urgent consideration and favourable action for Māori living in Auckland, especially those inhabiting tents or substandard housing in Panmure, a southeastern suburb. Harris called for the government to expand the rural native housing program to build houses in Auckland and allocate Māori families to state rental houses. The government responded by commissioning the Panmure Tamaki Housing Survey. Te Rangiatua Rangi Royal, the Native Affairs Chief Welfare Officer, carried out the survey in November 1944. He surveyed 259 recent urban migrants from rural areas including Northland and the Waikato about their housing conditions and requirements, income and health. Health was a key consideration for this housing survey. One of the families surveyed had a father with tuberculosis receiving medical treatment at Auckland's Greenlane Hospital. Another family had suspected tuberculosis cases. Royal argued that Panmure's location was ideally situated from, quote, a health point of view, being elevated and close to the sea, end quote. This was in accordance with contemporary ideas about health, which emphasised contemporary health ideas about housing location, and was one reason why Rangi proposed that state houses for Māori families should be built in the suburb. Royal wanted to prevent Māori children from being infected with tuberculosis through, quote, the provision of good housing in a healthy locality, end quote. Royal's references to children's health strengthened his argument that the government should fund a rental housing scheme for Māori families. Other considerations that Royal used in this report to campaign for this proposed scheme included unhealthy housing conditions and that many of these families had family members carrying out essential war work in Auckland or serving overseas for the war effort. Some were living in tents, others in old stables or sheds, or galvanised iron shacks. Nearly all of the homes in the survey were overcrowded and most lacked sanitary facilities. According to Royal, quote, the removal of these families from unhealthy and inadequate accommodation is a matter for urgent consideration. However, the Second World War delayed the construction of a state rental scheme as the conflict diverted building materials and labour away from the housing construction to the war effort. After the Second World War, government housing policy for Māori continued to struggle to meet housing needs, especially in Auckland. Although state houses began to be available for Māori families, financial constraints and building material shortages still limited the government's ability to provide houses to all those in need. In July 1945, the Health Minister Arnold Woodmeyer wrote to the Native Affairs Minister Rex Mason, raising concerns about Native Affairs houses. Woodmeyer thought that these houses were too small for their inhabitants, which he felt undermined the scheme's aim to improve Māori health through better housing. He noted that many of the houses were overcrowded. In September of the same year, Nordmeyer held a conference to work out, quote, the apparent conflict between the Health and Native Affairs departments about standards of publicly funded houses. Health Department officials at this conference criticised the Native Housing Program. Some claimed that Native Affairs was lending money for houses that were not large enough and did not have adequate sanitary facilities to ensure health, along with not providing sufficient money to construct all of the houses needed. George Shepherd, the Native Affairs Undersecretary, defended his department at this conference. Shepherd claimed that since the 1935 Native Housing Act was passed, his department had arranged the funding and construction of as many houses as possible. In common with other housing construction, his department's house building had been delayed due to wartime labour and materials shortages. By 1945, Native Affairs had funded and arranged the construction of 2,550 dwellings, 103 houses, and carried out renovations and extensions to 150 homes. A very small number of these houses were beginning to be constructed in urban areas, including Auckland, in the mid-1940s. But this was limited by the department's difficulties in obtaining urban land for housing sites and higher construction costs in urban areas. Shepherd emphasised that Native Affairs could only build with the funds that were given to it. This was an important consideration, as the Native Housing Program was consistently underfunded throughout this period. Children's health was a significant concern for those who campaigned for good publicly funded housing. An example of this was when Mary Lammy, the director of the nursing division of the health department, raised concerns at this conference about the health impacts of Maori families living in Native Affairs houses that were far too small, with not enough windows. Lammy blamed substandard housing conditions for the higher Maori infant mortality rate and cited cases when infants had suffered from pneumonia due to these conditions. She was particularly apprehensive about houses which have 14 to 16 people sleeping in one room. Lammy's concerns may have also been due to a different cultural approach to sleeping, as Maori often slept communally with their extended family and wharepuni, sleeping houses, compared to the Pākehā way of living, which emphasised nuclear families and individual sleeping arrangements. Maori housing policy was not just about improving health, but also about assimilation into a Pākehā lifestyle, as some historians such as Deirdre Brown and Ben Schrader have noted. More culturally appropriate housing policy, such as building houses that were suitable for extended families with large bedrooms, may have been more successful at improving Maori housing conditions than the provision of small houses only suitable for one nuclear family. By the mid-1940s, Native Affairs, which became the Department of Maori Affairs in 1947, had convinced the State Housing Corporation to build state houses to rent to Maori families. This followed Royal's 1944 housing survey, which had advised the government to build 1,200 state houses for Maori families in Auckland. The government extended the state housing program to include Maori families because neither private housing nor the Native Housing Program had provided sufficient healthy homes for them. The decision to include Maori in the state housing program was also a result of growing urbanisation. As increasing numbers of Maori families lived in urban areas, it was no longer practical to exclude them from the urban state housing scheme. By 1949, over 60 state houses had been allocated to Maori families in Auckland suburbs including Tamaki, Onehunga and Orake. This was inadequate to meet the housing needs of the approximately 10,000 Maori living in Auckland in the 1940s. After the inclusion of Maori in the state housing program, Labour still continued the Maori housing program. In 1948, Maori Affairs raised its specifications for its housing scheme to comply with the New Zealand Standard Code of Building Bylaws. This was in response to pressure from reports such as Royals for Maori government housing to be built to the same standard as all new houses. The new specifications insisted on full bathroom and laundry facilities for all houses financed by this department. These requirements stipulated that low-lying and damp sites were to be avoided. Ventilation and sunlight were also important considerations. Sleeping porches, like we've got a picture of this one on the slide, were built in some Māori affairs and state houses, as they were still continued beneficial for people with tuberculosis and to promote general health. Sleeping porches had come into fashion in sanatoria in the late 19th century to treat and prevent tuberculosis. They were still popular in the 1940s, but they went out of fashion as the medical treatments for tuberculosis improved at this time. These porches allowed easy access to fresh air and sunlight. Furthermore, a sleeping porch for a family member with tuberculosis was intended to help prevent the spread of this contagious disease. Maybe they'll make a comeback under COVID-19. You could do a bit of managed isolation for your family members in a sleeping porch. Conclusion. Government housing policy aimed to improve Māori health, improve ventilation, access to sunlight, and the use of sleeping porches. And new government-funded dwellings aspired to prevent and cure tuberculosis and other infectious diseases, and to promote health, especially children's health. Government housing programs also endeavoured to improve Māori health through reduced overcrowding and better sanitary facilities, but were not always successful, as many of the new homes were too small for their inhabitants or lacked adequate amenities, and most importantly, because these programs were underfunded. Attempts to improve Māori health through better housing were constrained by the Second World War and Auckland's ongoing housing shortage. However, whilst these constraints affected the wider population, the government did far less to help Māori than Pākehā, and this contributed to ongoing health inequalities. The underfunding of the native housing program meant that these houses were substandard compared to contemporary state houses and did not include all of their health-related features. Throughout this period, Māori homes remained more overcrowded, and Māori continued to have higher rates of infant mortality and infectious diseases than Pākehā. Thank you for listening to my talk, and let me know if you've got any questions.
Just trying to work out how to do questions.
Yeah, how do you do them with Zoom? Yeah.
Oh, we can switch you on to Zoom.
Okay.
Easy. So get rid of that and pull up. Let's stop sharing that screen, and there you are. You can see everyone who's done.
Brilliant. We might need to unmute them as well.
No, that's their problem.
Oh, okay. They were self-muted. Okay.
If you want to unmute yourselves, unmute yourselves. And hopefully when you speak, we'll be able to hear you. Is there any questions?
Could someone try speaking in there just to see if it
Can any of you actually, could one of you speak, please?
Mike, maybe?
Mike?
Mike, you're there. Would you say a word or two? Hello, I can
Oh,
hear
there
you.
we go. We can hear you.
We can hear you, good. I had a question. When I looked at the Maori Councils Act, there was quite a range of the bylaws that related to health and improving the health of Maori people in the early 1900s.
Definitely. This was an ongoing trend. This was, there'd been a drive to improve health and better housing in the early.
But in the 1900s, they were underfunded, and in the 1940s, they were underfunded.
Yes.
The underfunding is the consistent thing, and improving health is consistent.
You can argue that even in 2020, they're still underfunded. There are still housing programs which are underfunded.
So there's not really been a big difference.
No, it's an ongoing trend that I definitely found throughout. There was this real drive to close these health disparities through better housing, but these programs were never given enough funding to carry out, to build all the houses that were required. They did improve things, but it was not enough. I mean, we did have a narrowing of the health disparities during the post-war period, but then increased again in the early 1990s. So there was a narrowing and then a widening again through a successful state housing program.
Can I ask, I came across this really neat thing by the Māori Women's Welfare League, where they've done a big survey.
Yes, I wanted to.
Could you repeat the question?
Well, the Maori Women's Welfare League, unfortunately, it was established slightly outside of my time period. My supervisor, the Maori Women's Welfare League have done this great survey. Aroha Harris has looked at their work, and I was told that 1918 to 1949, The thesis is already 100,000 words. You know, we've got to just stop somewhere. But yes, it's a great piece of material, and I'd love to return to it and look at it in more detail. And there's an upcoming, although I'm not wearing my Waitangi Tribunal unit hat today, there is an upcoming housing inquiry that hopefully will be looking into that, and hopefully I'll be part of that project. But you're right, and that was a really important survey, and it did show what I was finding in my research with earlier housing surveys, like Rangi Royal's one in Auckland.
Thanks, Elle. That was such a great talk. I'm just wondering about how the housing connected with other kinds of services. Were there health clinics built in association with these public housing areas?
Oh, it was more that.
Repeat the question.
Oh, okay. Were there health clinics built in association with these housing areas? It was more actually, I don't know if you've heard about the nursing scheme. You know, they had nurses going out to these communities, like for instance in rural Northland, which I was initially going to look at as part of my thesis, but again, it got too big. So you'd have these nurses going around, and they're really involved with public education. And where Dr. Harold Turbot, he carried out a survey of tuberculosis, a Maori living on the east coast of New Zealand. So there's very much, you know, there were medical officers going out and working alongside, because public education about health was seen as really critical, especially in the following the influenza epidemic of 1918. There's this real interest, we need to educate everyone about how to improve health. But that was continuing on from efforts through the native schools, would actually provide health education, and the teachers would actually provide healthcare, some, you know, basic medicine to their students. So there was those sort of associations. I wouldn't, you know, the clinics were very much more the nurses going out into the community in these rural areas. Perhaps clinics were more sort of came later with the urban migration. But definitely health education was seen as very linked to housing. And it was also, they were taught about how to live, you know, in these new homes, and opening all the windows, you know, ventilation was such an interest at that time period.
In the 1940s, we're also seeing the Plunkett
Yes.
rooms being set up.
However, Plunkett nurses didn't tend to Maori communities in that time period. There's an excellent history of Plunkett nursing Plunkett in New Zealand, written by my PhD supervisor Linda Ryder of Voice Mothers, which talks about the history of Plunkett nurses and Maori, and how that they were originally not attended by Plunkett nurses.
I think Marina has a...
Oh, have we got a question from the Zoom?
Yes, hi. I just wondered why you chose that time period.
Because it's a wonderful time of change. You've got all this change happening. You've got this real interest. You know, we've got there's Maori moving into these cities. It just raised the profile of the issue. It becomes a much more visible issue than during, you know, the early 20th century, when they tended to live in more rural areas. We've got this new housing program. We've got debates about whether they should be included in the state housing program. I find early 20th century New Zealand is such an exciting time, because it hasn't always been that researched in this field, and there's so much change going on. I just, that's how I chose the time period, yeah. Does that answer the question?
Yeah, and I just thought about, you know, how much building would have happened during the Second World War.
Yeah, well, there was not actually that much building going on in the Second World War, but certainly post-Second World War, there was a lot of building. And once the Labour government was elected in 1935, there was a lot of state houses being built, you know, tens of thousands every year being built. Then there were thousands, you know, a couple of thousand native houses built during this time period from 1935 through to the into the 1940s. So you've got, you know, a few thousands of houses being built. But there was a bit of a breather during 1939 to 1945, definitely house building. Construction slowed down then.
Thank you very much.
In America, the return of the men, and they were all mainly men, from the First World War, there was a lot of unhappiness at the quality of the housing, whether it was fit for returning heroes.
Yes.
And that put a huge emphasis on the development of better quality housing for everyone.
Definitely. It was exactly the same in New Zealand. We had a very limited sort of funding provided to councils to build houses around New Zealand for returning soldiers, but this was critiqued. There weren't enough houses built, there weren't of a high enough quality, and there was a much more of an agreement during World War II. We have to build decent homes for returning soldiers, whether they're Māori or Pākehā. They are worthy, and also there's this real interest in children's health at this time period. We've got a declining birth rate happening, we've got 2 world wars, they want to replenish, they're like, all our children are precious, we've got to look after their health to create, you know, there's a real interest in preventative health in this time period, which I think is really key.
Right, well, I guess we're spot on time. Are there any other questions online or in the room? In that case, I'd say thank you very much, Ella, for a very interesting talk. Pity it wasn't in architecture, but we have to have historians too.
Well, like I said, we bring our own perspectives.
Yeah, that's right. Thank you so much. And
Yeah.
you can have virtual claps from there and some claps from in here now.
Thank you.